Welcome to today's Observatory webinar. My name is Ewout van Ginneken. I'm the Director of the European Observatory on Health Systems and Policies, and I will be moderating today's webinar together with Erica Richardson. Erica will keep an eye on the chat, so if you have any questions during this webinar, please post them there. The webinar will be both in English and also Ukrainian. You can select at the bottom the language. If you have problems, we'll leave an instruction in the chat. This webinar is the first of two webinars on rehabilitation care and based on a new policy brief that we have developed together with the European WHO Regional Office and also the Ukrainian office, WHO Ukrainian office, and also together with the Barcelona Financing Office of WHO, explicitly to support Ukraine in developing rehabilitation care. But it's also written for an international audience. The topic is strengthening rehabilitation care, and we're focusing on the evidence for organizing service delivery. The other webinar will be focusing on financing. Rehabilitation helps patients with the loss of function and independence and are increasingly important as population age, but also in the face of conflict-related injuries. Often rehabilitation services are very fragmented, but integration and coordination of care can overcome the gaps in continuity and lead to better patient-centered care. Some of the questions we would like to address are: what coordination strategies support effective rehabilitation? What are the key enablers for success? And also, what are the key challenges going forward? Before we go to the keynote and spotlights from the UK, Croatia, Ukraine, and WHO, let's hear first from Jarno Habicht. He's the head of the WHO country office in Ukraine. Jarno, over to you.
Good afternoon, good morning, good evening. It depends from where you are connected. Greetings from Kiev. My name is Jarno Habicht. I'm the WHO representative in Ukraine. And thank you actually for support that European Observatory is providing to WHO. It's a collaboration, as you mentioned, of WHO European Office, WHO team in Ukraine, our health financing team in Barcelona, but most importantly, the network that European Observatory has and that has made that policy brief available. A dream come true. We discussed a year ago that we need more evidence how to scale up rehab services in Ukraine, what we can learn from different countries. And there is no better partner than European Observatory to do such cross-country comparisons. So thank you for the partnerships. And also today we discuss about the study. I think rehabilitation is a cornerstone for recovery and resilience, as we see in Ukraine. It is important for people to regain independence, return to work when or to study, continue to be with their families, communities, ensure the economies are moving. So there are so many different outcomes and outputs. But today we look to spotlights on service delivery part, and in a few weeks' time, we look more to health financing. In Ukraine particularly, we have seen the need for the rehab services since the start of the war and Russian Federation invasion in 2022 to exponentially increasing. So we need to ensure that the services are there. And that's why this study, because it helps us to find the ways how to scale up the services fast enough. Last month, we met in Kiev. We discussed how to strengthen the rehab services. And we saw that actually this policy study is extremely valuable for decision-making and helps us to move from theory to practice and action, but also learning from each other. And I think today's webinar is exactly about that. And I'm very happy to see those colleagues who are sharing. I'd like to thank also many colleagues involved and European Union in particular, making the financing available that we can come together, collect the evidence, share the evidence, and think how we can do more and better for people in Ukraine and across the world. So back to you, Ewout. Thank you for the partnerships. And I hope that we will have many of the listeners with us and many people to read the report and then come back to us how we can do better. Back to you.
Thank you very much, Jarno, also for the kind words. It's really great that we can help support Ukraine in this way and working together with you more. And indeed, also, let's work more in the future. Now over to the keynote. Erin Webb will provide the keynote. She's a researcher at the Technical University of Berlin, and she will provide some key findings from the policy brief relating to service delivery. Over to you, Erin.
Thank you, Ewout. And hello, everyone. My name is Erin Webb, and I am one of the co-authors of the recently published Observatory Policy Brief on Strengthening Rehabilitation Care. Today, I'll share some of our findings related to organizing service delivery for rehabilitation. So to kick things off, what motivated this work and why at this moment? As you heard from Jarno, rehabilitation has become a key topic for the health system of Ukraine and the WHO European region more broadly. Rehabilitation supports individuals in regaining their health, optimizing their function throughout daily life, and improving their well-being. It also enables participation in education, work, and community life, thus contributing to broader societal and economic benefits. The baseline demand for rehabilitation services is increasing as populations age and chronic diseases rise, and as Ewout mentioned, in conflict zones, trauma injuries also require rehabilitation services. But despite the need for rehabilitation, many health systems face underfunded and understaffed services, as well as inefficient use of existing resources. This adds pressure to already strained health and household budgets. While additional resources would help countries meet demands for rehabilitation services, there's also the opportunity to achieve better value for money. For this study, we used a qualitative cross-country comparative approach. We identified policy options for how to increase efficiency and strengthen rehabilitation care. We purposefully selected 14 countries from the WHO European region to ensure a rich, relevant, and varied set of case studies. We sent out a questionnaire to all countries to understand how rehabilitation services are organized, so which settings of care rehabilitation services are provided, what the patient pathways look like, and what professionals are involved. We also wanted to know which rehabilitation-specific services are covered, what the eligibility criteria is for these services, and whether there are any limits on utilization. And then we collected data about how rehabilitation services are purchased, including the sources of funding, the contracting approaches, and the provider payment mechanisms. This webinar will focus on the organization of service delivery across the 14 study countries, while the next webinar in this series in a few weeks will focus on the financing topics. Today, I'll structure the webinar by sharing 3 challenges that we found that countries are facing in delivering rehabilitation services. And for each challenge, I'll highlight some strategies that help lessen the impact of these challenges. First, rehabilitation services are inherently fragmented and dispersed. In other words, specialized higher intensity rehabilitation services are mostly provided in dedicated inpatient rehabilitation centers or hospitals, while lower intensity services may be provided in outpatient or primary care settings, in some cases at home or even remotely. On top of this, many different specialties are involved, depending on the patient diagnosis and what kind of rehabilitation is required. This fragmentation of settings and providers makes it difficult to provide continuity of care for patients, and it also has the potential to reduce quality if patients drop. In terms of the strategies to lessen the impact of this challenge, a key component is a dedicated care coordinator or case manager to help patients navigate the rehabilitation process. This role allows patients to have a single point of contact throughout their rehabilitation journeys, and facilitates transitions across care settings and providers to help navigate the system. Respondents particularly noted a challenge in care coordination that occurs at patient transitions, such as the hospital discharge process. Therefore, structured and more predictable processes and shared care plans at patient handoffs can facilitate care continuity, as do electronic records that are accessible to all members of the care team. Another strategy we found is integrating primary health care with rehabilitation. In Spain and Israel, rehabilitation is more directly integrated with primary care to more deeply connect rehabilitation across settings. So let's look at Spain as a case study about the role of primary healthcare in rehabilitation. This illustration shows the patient pathway for a stroke patient in Spain. The dark blue boxes show where care is provided in an inpatient setting, while the light blue box on the right denotes that care is provided in an outpatient setting. The colored circles at the bottom represent all of the various healthcare professionals that may be involved in the treatment. So as you can see, there are a lot of potential roles that may be involved. These could include physiotherapists, speech therapists, occupational therapists, neuropsychologists, specialized nurses, and even more depending on the patient's needs and functional objections for recovery. There are 3 phases of stroke recovery identified in Spain. First, the acute phase occurs within the first couple of days and includes the early assessment and creation of the therapeutic plan. Here, all relevant healthcare providers come together to create this plan, and the rehabilitation physician then trains the family or caregiver on this plan for helping the patient. The second phase, the subacute phase, kicks off with the discharge process and specialized rehabilitation. And third, the chronic phase includes ongoing rehabilitation. This may include complementary community-provided services, such as social care, return to work assistance, and psychological support. In the subacute and chronic phases, the primary care physician coordinates rehabilitation care, illustrated by the pink shading in the figure. And by having one care coordinator for all of this outpatient rehabilitation and the various needs, patients can more easily navigate the various healthcare providers, settings, and professionals that are part of rehabilitation care. A second challenge that we identified relates to the settings of care. Often there is a misalignment between the intensity of the rehabilitation needed and the care setting where the rehab is conducted. Specifically, many countries offer rehabilitation services in the inpatient setting, even when the care could have been provided in an outpatient or home-based setting. This leads to higher costs. One strategy that can mitigate this challenge is to locate rehabilitation professionals directly in primary care rather than in inpatient care. In England, some patients may have their first contact with the physiotherapist rather than a GP, which has the goal of reducing burden and increasing access. In other cases, such as Italy, telerehabilitation services have been introduced to promote home-based care, to reduce costs and increase access, particularly in remote areas. Another strategy we identified was to shift tasks to rehabilitation assistants and non-physician providers as a way to reduce costs while maintaining quality. The third and final challenge I will highlight in today's webinar relates to utilization, and in particular, the risk of providing unnecessary services. This, of course, comes at a high cost and may miss more important demands for rehabilitation in the population. There are 2 approaches to this challenge that fall on a spectrum. On one end of the spectrum, countries can set specialized and standardized eligibility criteria, for example, at the national level, that determines the treatment protocol. This is the approach taken in Croatia, Poland, and Lithuania. On the other end of the spectrum, countries can rely on the treating professionals to develop the treatment plans for the population. This was identified in England, Spain, Ukraine, Norway, and Turkey. In both cases, countries can have limits on utilization, for example, only a certain number of hospitalizations per condition, or cap services, for example, only a certain number of appointments per patient. When considering how to overcome this challenge in utilization, it is important to align the benefits that a patient is entitled to with their clinical need. To wrap up, I'll share some conclusions around our findings in delivering rehabilitation services. In organizing service delivery for rehabilitation care, care coordination is key to integrating the care provided by the various health and rehabilitation providers. Countries where primary care physicians serve as patient coordinators of care, such as Croatia, England, Israel, and Spain, naturally rely on them to organize the majority of outpatient rehabilitation. Another approach is to have dedicated case managers, especially for certain conditions like stroke, to steer patients through the system. The goals of this care coordination ensure including the rehabilitation and primary care professionals work together, patient transitions such as hospital discharges have continuity of care, and patient information is shared with the health professionals that need it. However, this coordination takes time and effort, and it also builds on the existing health system infrastructure even beyond rehabilitation. And policies and payment systems need to recognize this. Then related to coverage and eligibility criteria, having standardized guidelines, protocols, and clinical pathways are a good starting point. Here, the goal is to have effective mechanisms for allocating patients to the most suitable and least costly setting and package of care, especially for high volume conditions such as lower back pain. Again, there's a balance between standardized national guidelines and delegating decision makers to health professionals, and different strategies may fit for different rehabilitation scenarios. Before wrapping up and handing it back to Ewout, I wanted to acknowledge that this work would not have been possible without the national experts who provided their valuable insights and data, as well as the support from the WHO country office in Ukraine, reviewers, and wider WHO contributors. So thank you for your attention, and I look forward to your questions. Now I'll pass it back to Ewout for the country spotlights.
Well, thank you very much, Erin, for providing this important overview. And if you need to know more about all these, because this was just the tip of the iceberg, do download the full publication, which the link you can find in our chat. So thank you very much. We're now going to dive into the country perspectives, the country spotlights, and we will first start with Mark Dayan, who is a policy analyst and head of public affairs at the Nuffield Trust. And he will be talking about, well, actually England, probably not the UK. Is that correct, Mark?
That's right, yes. So I'm going to share my slides and discuss two different initiatives for reforming or improving discharge that we have in England, both of which often will involve periods of rehabilitation given to patients after discharge from hospital. So the first of these is care transfer hubs. These are, at least as a nationally consistent project, they're relatively recent, introduced in 2022 as guidance. That's something that all hospitals should be providing. The idea is that England is a system where discharge and rehabilitation are handled by many different parts of the system, by general practice, by hospital trusts doing inpatient rehabilitation, by community trusts, which we separate out, and by social care, which is often private, and it's a different system in the English context. So these hubs bring those services together, usually with a physical location, but also in terms of identifying professionals in a multidisciplinary team to try to coordinate discharge better. You'll see at the left of the slide, we have the different pathways that we would define for discharge in an English context. Pathway 0 there is simply you go home, you don't require further support. The higher three pathways which involve a new or extended need for care and support, those fall within the remit of the care transfer hub. So this is a service that's typically commissioned in its own right locally. Guidance suggests it should be led by a single discharge coordinator answering to an executive, and each patient should have a case manager. The purpose of this is to bring together the different professionals, usually to arrange fairly rapid discharge. And this is associated with the idea of discharge to assess, where the patient goes home and then usually within 2 hours is assessed in terms of their ongoing needs for rehabilitation, district nursing, social care and other things when they are at home. And plans for their ongoing care will be drawn up at home as well. Typically, you would see the NHS providing 4 to 6 weeks of rehabilitation in a context like this. We'll come on to the context of stroke, where that's more uniformly the case. This is usually a 7-day-a-week service with an aim to discharge most patients by 5 p.m. so that any family support or social care support that happens where they live can handle that without too much difficulty. The next initiative that I'm going to just share with you is early supported discharge for stroke. This is a much more long-standing initiative, goes all the way back to 2007 and has been part of formal guidance since 2016, but it's still quite insufficiently taken up. Only around 1 in 4 hospitals in England will have rolled this out in full. The hospital stroke team is supposed to decide who's eligible for this, and it's typically assumed that around 40% of patients may be eligible for it. It's really for those who have mild to moderate levels of disability. The idea is simply that they go home or they go to where they live, and they receive the 2 to 6 weeks of intensive rehabilitation that they typically receive as inpatients in the setting of their homes. There are different models for arranging this. So one is what's called outreach. So that means that the acute team in the hospital plan a discharge to home. They will actually even design things like home adaptations, and they will go to the person's home and provide rehab themselves for around 2 weeks, then hand over to the community services which provide most rehabilitation in England. The other model is actually that the community-based rehabilitation team, who usually work in people's houses or go into care and nursing homes, they go into the hospital, contact the patient before they leave, and begin putting plans in place with consultation with family or carers where that has the patient's consent. It's typically assumed that the early supported discharge program will involve about 5 sessions a week of physiotherapy, occupational therapy, or speech and language therapy for 4 to 6 weeks. The evidence base for this is reasonably borne out, at least in its initial form, for reducing cost by 10 to 20% by moving the patient on from the hospital setting to the place where they usually live. There's been more debate about whether or not it improves outcomes. Original evaluation showed it did improve mortality. More recent papers have cast some doubt on this, but it certainly seems to be associated with greater planning and people receiving a more intensive level of support than they do in inpatient, which is interesting. And as I say, this has been rolled out to around 1 in 4 trusts in England, but there can be real problems with who funds it and whether everyone's ready to have this model. So I'll just close with some overall thoughts on the introduction of these and other initiatives in England. I think it's important to say that they're part of a very wide suite of initiatives developed at different times to try and include discharge. Others include, for example, a central funding pot which supports particular packages of care in social care, nursing or domiciliary care. Others deal with virtual wards and the ability to provide monitoring on an inpatient standard in people's home using telemedicine, telecare. There isn't really an overall strategy that brings these different initiatives together, or that brings them together with some of the other initiatives we heard about earlier, like direct access to physiotherapy as an overall plan for rehabilitation. And measurement of the system's success in improving outcomes or activity is quite limited. There have been evaluations of most of these activities, but they don't typically have ongoing success measures that are widely reported and seen at the level of the whole system. Overall, despite these initiatives and despite an increased emphasis on discharging patients safely, funding in the English health service has continued to flow mainly into acute care, ambulance care, and mental health care. If you see the red line below 0% there, that's community healthcare by NHS trusts. That's where most rehabilitation sits in the English system, and it's a part of the system that's done relatively poorly financially. And that, I think, is associated with the fact that while these initiatives exist in some areas, there's good evidence in some areas, there's real buy-in and there's money behind them. In other parts of the country or other acute hospital sites, they simply don't. And even when they do, there can be a lot of inconsistency. So with that, I will hand back, stop sharing, and go to the next speaker, but I'm really happy to take questions in the Q&A that I know we have at the end.
Thank you very much, Mark, and really good to show that often a strategy is lacking, which is something that we don't often see, and I think it reflects the fragmentation of the system really well, unfortunately. Okay, so let's go to Croatia. Let's hear from Dorja Vojanek. She's a researcher at the University of Zagreb and Andrija Stampar School of Public Health, and sharing with us a perspective from Croatia.
Hi, happy to be here, and cutting any long introductions, I will go straight to the types of rehabilitation services we have in Croatia. So there are basically three types or settings for the service provision. First is in-home physical therapy. This is basically for people who are immobile or have a severely mobilely impaired due to any health condition. And this type of service is provided by physiotherapists. There is a defined list of activities that could be provided in home, and it usually lasts up to 15 days. Second one is inpatient medical rehabilitation. This is provided in specialized hospitals. They are spread out regionally, but some of them serve as national centers. So, for example, patients who have cranial injuries would all go into only one specialized hospital in Croatia. And the same goes, for example, for the cardiac rehabilitation and so on. Most of them are actually for locomotor system rehabilitation. The criteria is inability or inappropriateness of outpatient rehabilitation, which you can see is pretty vaguely defined element. And the patient needs to have Bartle index lower than 80. And also there is a list of eligible medical conditions for this type of rehabilitation. It can last up to 21 days. And the third is outpatient medical rehabilitation. It could be provided either in general or specialized hospitals. So also these specialized hospitals that you see on the map in the back of the slide. But many or almost all general hospitals, we have at least one in each county, have departments for physical therapy and rehabilitation, so that can be provided over there. Specialized hospitals also have accommodation, so there is a possibility for patients who are not eligible for inpatient medical rehabilitation. They get a referral for outpatient medical rehabilitation and then pay for their own accommodation and meals, and are then basically in the same program as the inpatient ones. There are two different processes for proving type of rehabilitation. So for in-home and inpatient, the difference is that the Croatian Health Insurance Fund actually grants approval, because all of this is within the mandatory health insurance scheme. Jumping to the challenges. So all of this is defined in the rule book that is from 2007, it is a bit outdated. So we would need, and there is room to improve the needs and also how we use services to analyze this and then revise the criteria based on that. For the in-home physical therapy, there is maybe a lack of physiotherapists, especially in some rural and remote areas. And given our demographics, a lot of people who are eligible for this type of therapy. So many times they cannot really exercise it, even though they are eligible and have a right to this service within the health insurance. And then also what we see in practice is many patients that have degenerative conditions and are not expected to functionally improve, that use inpatient and outpatient rehabilitation services, and they actually use this as a substitution for their everyday physical activity, which is of course not sufficient. So to conclude, what we think is lacking here is the criteria officially of expected measurable improvement that would then officially lead to better prioritization of patients and also to timely rehabilitation for conditions that needed. Happy to answer all the questions in the Q&A session. Thank you.
And I'm sure there will be questions for you, Doria, later. Thank you also for sharing that and on showing the importance of measurement, which was also something that came across from most case studies, that we need to know more and have to do a better job there. Okay, let's now move to Ukraine, to Andriy Vilensky. And Andriy is the advisor to the Minister of Health, and I'm very glad that he's here, probably taking time from us in a very busy schedule. Andriy, over to you.
Today, I will outline the main stages of and challenges in Ukraine rehabilitation system. So in 2011, the Ukrainian Physical Therapy Association joined the World Confederation on Physical Therapy, and marking the start of the international standards adoption. In 2020, the law of rehabilitation in the healthcare sector was adopted, which defines the competencies and responsibilities of specialists. So, and also in 2020, as you see, rehabilitation received funding through the program of medical guarantee, and making services more accessible for the patient. The COVID-19 pandemic was a challenge, but rehabilitation service quickly adapted, developed new protocols, and integrated rehabilitation into post-COVID recovery programs. With the outbreak of full-scale war in 2022, rehabilitation became critically important to help military people and civilians with severe injuries and their subsequent integration into public life. Please, next slide. So in Ukraine, what is the rehabilitation system in Ukraine now? In 2025, we have 569 healthcare facilities providing rehabilitation services, 372 of them inpatient and 523 outpatient, 165 for children under 5 years old. And now we have 16,000 therapeutic sessions are conducted daily, which is 5 times more than in 2022. Next slide, please. What is the key challenges and development opportunities in Ukraine, in Ukraine's rehabilitation sector? So now we have several challenges. First of all, historical context. Infrastructure needs modernization and full integration of rehabilitation into the healthcare system. The war affected the availability of medical personnel, especially nurses and rehabilitation specialists. It's important to develop multidisciplinary teams too. Only 15% of stroke patients in Ukraine now receives specialized rehabilitation care. In the context of resource constraints during war, a balance needs to be found between developing rehabilitation for military civilians with acute illnesses and injuries and patients with chronic diseases. And hundreds of health facilities have been damaged, and the number of patients with field injuries has increased. And now ICF has been implemented for coding mostly, but there is potential for further qualitative assessment of rehabilitation. Next slide, please. What are the lessons has Ukraine learned in the field of rehabilitation over the past 5 years, developing in conditions of permanent crisis? The state must determine development priorities, allocate resources, and actively participate in the allocation of resources and coordination of partnerships. Creation and development of centers of excellence, which serve specialized institutions that disseminate experience, develop standards, and provide feedback for policy of formation is crucial. An international partnership is very important for attracting additional sources for funding, expertise, and technologies. This will help in the development of a network of institution coordinations and implementation of successful solutions on the ground, which is necessary. We must keep the balance between local experience and international standards to ensure adaptability, efficiency, and transparency in the development of rehabilitation system. Thank you very much for your attention.
Thank you very much, Andriy. And it's really truly inspiring to see what Ukraine has managed to do under such unprecedented challenges. And I think one of the issues you flagged was financing, and in 3 weeks we will be talking about financing in this webinar. So thank you, and also in the Q&A, also have your questions for Andriy. Okay, so we will go to WHO, to Marley Quinn. She's a Disability and Rehabilitation Unit Lead of the WHO Country Office for Ukraine. So Marley, over to you.
Thank you, and good afternoon from Kyiv, Ukraine colleagues. So I've been asked to speak briefly on ways in which we can promote best practice in rehabilitation service delivery in Ukraine. So I think it's clear from other speakers that the model of rehabilitation and what rehabilitation is more or less clear. But I think it's important to point out that rehab is part of universal health coverage. It's a service and a set of interventions that can promote good health, prevent disease, treat disease, injury, etc., and also should be available in palliative care. It's a set of interventions which is can support a child, an adult, or including an older person to be as independent as possible. We know that rehab services should be integrated at all levels of the healthcare system, and a multidisciplinary rehabilitation workforce is essential to delivering rehabilitation in healthcare. So as my colleague Andriy mentioned, rehabilitation has been rapidly developing in Ukraine over the last 5 or more years, 5 to 10 years. At the moment, we have roughly 22,000 individuals available to provide rehabilitation across the key areas. Speech and language therapists, rehabilitation nurses, and prosthetists and orthotists have most recently been recognised by the Ministry of Health and Government of Ukraine more broadly. So just a quick snapshot of service coverage in Ukraine at the moment, and Andriy certainly touched on this also. We have, with regards to specialised high-intensity rehabilitation, we do have our National Spinal Cord Injury Rehabilitation Centre, which was developed in 2022 and continues to provide high-quality spinal cord injury rehabilitation. We do also have services available in Ukraine which specifically address traumatic amputation. However, for the most part, these services are available outside the public health system in Ukraine. What is lacking is specialised services that can treat people with complex limb injury, traumatic brain injury, burns. So we know in Ukraine, most unfortunately, complex traumatic injuries are occurring every day in quite large volumes, and often these patients will not reach rehabilitation or see a rehabilitation professional until weeks or months into their healthcare journey. Most of the rehabilitation services in Ukraine are currently focused in the subacute inpatient setting. And as Andriy demonstrated, there are many at this moment in time. And typically you'll find mixed caseloads in these units, including musculoskeletal conditions, neuro, some trauma, and many, many non-complex cases such as lower back pain, etc., that would essentially be better treated outside of a secondary or tertiary healthcare facility. In terms of primary healthcare, rehabilitation is not formally available, but I think over the next coming years, we may be able to promote some sort of very basic interventions, but really the focus at the moment there is being able to promote referrals, identification of rehabilitation needs, etc., with family physicians and primary healthcare nurses. And finally, on community-delivered rehabilitation, this is not formally available either. However, the WHO in Ukraine is actively working on piloting service delivery models alongside the Ministry of Health and the NHSU to look at developing some recommendations for policy and financing next year and certainly for 2027. So just one example of how we've been able to utilize international best practice to promote better service delivery in Ukraine. And I touched on the National Spinal Cord Injury Rehab Center earlier. This is truly a collaborative effort where we had much support from the International Spinal Cord Society and also later on from the International Society for Wheelchair Professionals. And you can see here the various areas that we worked across where we brought over multidisciplinary rehabilitation teams for bedside training, targeted workshops, etc. And this was really a process that evolved over the last few years. We're now at a moment where the national rehabilitation team from Ukraine are able to go forward and provide specific specialist training in subacute spinal cord injury rehabilitation, but also acute spinal cord injury rehabilitation. And we continue to develop the rehab pathways for people with spinal cord injuries, etc. So finally, in terms of priorities for improving service delivery going forward, we continue to address rehabilitation education, which is really critical to improving the capacities of the upcoming rehab professionals, ensuring high quality continued professional development opportunities for the existing workforce. Andre mentioned, and I fully agree, that upskilling the workforce in acute rehabilitation management and community delivered rehab, but also pediatric rehab service delivery is really critical for the country at this moment. An organisation of and rationalisation of our financial and workforce resources is critical because, as I mentioned, our services are focused in the subacute inpatient setting, and many people in those beds would be better served in other areas of the healthcare system. There's ongoing development and implementation of clinical protocols for Ukraine and guidelines to support better rehabilitation practice. I've mentioned defining clinical pathways for spinal cord injury, but this is very much relevant for many of the key conditions, particularly for those complex trauma patients who are coming from Eastern Oblast, from frontline areas, and making their way through the healthcare system over into safer, more longer-term settings. We're working at the moment on improving visibility of rehabilitation practice and quality monitoring of functional outcomes via the eHealth Central database. We're working to promote prosthetics and orthotics provision inside healthcare facilities and delivered by a multidisciplinary rehabilitation team, and also working with various institutions in the European region to generate Ukrainian rehabilitation research.
Marley, can you wrap it up really quickly because we need to go
Yes,
to
this is it. Here's a list of the tools that are available, and Erin will drop the link in the chat if you'd like to have a look at any of those. Thanks, Ewald. Back to you.
Thank you, Marley. That is a really impressive list of activities, an impressive list of publications, and we're happy also to contribute to that. And it's good to do more research on rehabilitation, also seeing the resonance we see among the audiences. All right, let's go to Erica. It was a long wait for you, Erica. A very active chat, I believe. Tell us some of the questions from the audience, and then we'll try to do one, perhaps two rounds if we are disciplined and short.
Okay. Yes, very lively chat. Very interesting themes. Many of the themes coming up are around financing and funding, which we're going to be covering in the next webinar on 25th November. So please do join us for that. But with regard to the funding, and a lot of the questions around service delivery are about how do we work across the boundaries between primary and secondary care. So how do we integrate services for rehabilitation and work across these sort of boundaries. Those boundaries can be sort of logistical or they can be financial, but if you've got any insights into that. And how do we improve coverage? Because lots of people are saying, particularly for the less acute rehabilitation services, a lot of it is being financed across Europe out of pocket, privately. So what can we do to improve coverage for those people? And thirdly, advice for scaling up services. So this is probably more for Andri and Marley, but how do we do it? And what recommendations would you give for those people for those countries that need to rapidly scale up rehabilitation services? Back to you, and I'm going back into the chat box.
Yeah. Okay. So I think the way we do it is Erin will be able to give a final comment. So I'm just going to skip you for a moment, if you agree, Erin. And let's put those questions to Mark and to Doria, especially the first ones on how to integrate between primary, secondary, and how to improve coverage. And then we can indeed go with the final question about the scaling up to Marley and to Andri. So Mark, would you like to kick us off? And please be brief so that we have the opportunity to hear from many of us. Thank you.
Definitely on the approach to integration. Look, I mean, I think this has been a difficult challenge in the UK, and that's probably associated with the fact that some of these initiatives are not widespread. So approaches that have been used span a very wide range. The care transfer hubs that I described, that was a national instruction simply sent out as part of a wider plan to recover urgent and emergency care following the pandemic. So in some sense, it's mandatory, and it tries to use a change mechanism, I think, of connecting services that already exist locally through a single point of executive responsibility. And that has achieved fairly wide uptake of this as a model. But of course, it does mean that there's still quite a lot of variation based on the capacity there was locally to be joined up in the first place and the level of funding that's put in for the breadth of services that the local area will cover, which does vary regionally in England.
Yeah, shall we go to Doria? Maybe you want to take the coverage question more, but we can also talk about the coordination.
Yeah, thank you. In Croatia, we are in a good position because all physical therapy and medical rehabilitation is within the mandatory health insurance. So I think our patients are broadly covered. What is maybe a bigger problem is how to define what the kind of therapy is appropriate in terms of improving their functional status all over. Because now we see, now we have a situation where many people having back pain, neck pain, or any other joint pain, and so on, actually use the outpatient or inpatient even services for 1 or maximum 2 weeks a year, and it's not enough. So some kind of continuous physical therapy would be better in this situation, and then having inpatient places for people who really need it after some acute disease or happening. So what we see is the space to improve this criteria in relation to the types of services that are the most appropriate for the people.
Thank you. So, and also, so it's coverage is not the issue. It's also more the accessibility of service, understood, no? Okay.
That's right.
So you need
yes.
better criteria. All right. Okay, let's move then to Andri. Could you talk a little bit more about the scaling up? You're right in the middle of it before we go to WHO.
Yes, thank you for this question. So at the beginning of the war, Ukraine had a lack of resources, and we had increasing demand for rehabilitation in our continent. And what is the right solution in this situation? First of all, the role of state authorities increased. And we understood that Ministry of Health of Ukraine and National Health Service of Ukraine should allocate the resources, first of all, money. And the key solution for Ukraine in this situation was creation of Center of Excellence. And this center, as I mentioned, disseminates the experience, develop standards, and provide feedback to policy of formation to Ministry of Health and National Health Service of Ukraine. It's a crucial part of development of rehabilitation sphere in Ukraine now. And now we have more hospitals and more providers in our country, which demonstrates the evidence-based practice and which provides the services for our patient if we had before the war in 2022. Thank you.
Thank you. So maybe go to Marley and perhaps also Jarno for a short comment on this. We saw there was an impressive list already. What do you see as some of really the key enabler for implementation and scaling up, Marley? And then to you, Jarno.
Yeah, thank you. And I agree with my colleague Andrei. I think in terms of advice for others, it's data and more data, looking at what the needs are. I think one of the critical challenges that remains for us in Ukraine is the lack of data on the specific needs of people who would require rehabilitation services. And obviously, you know, that's complicated by martial law, etc., and security restrictions. So, but this is really critical before planning any service, and also data on workforce. So what is feasible? Not more rehabilitation beds, more rehab units does not always equal quality rehabilitation services. So we should be guided by what the needs are, or what we have to meet those needs, and being strategic in terms of how we design pathways and allocate the workforce to meet those needs. Over.
Thank you. Jarno, would you like to come in on that? Also a broad challenge in all the countries that we looked at data.
I agree with much that has been said, and I think it has been encouraging to see some of those spotlights because it shows us how different countries are trying to solve the same challenge, but in different ways. And I think Marley and Andrei have been looking particularly how to scale up. I think few comments, if I may. One is rehabilitation, as we have heard, is needed on the peacetime, but it is even more needed at the wartime. But we should not forget that we have more patients because of the war, but at the same time, we need to support all of them who have had stroke, injuries, not because of war. Mm-hmm. So actually, you need to scale up because of both. And it is exactly at the time of COVID, we should not forget all the other diseases. So actually, the uphill battle is a huge. And that's why we need to have data. I think health, the professionals is important, and how you can combine actually the humanitarian support in service training and the basic training. And you need to have a thinking for next 20, 30 years. And at the same time, you know that you cannot serve everybody. And that's a challenge. And final point, that we should not forget the patient on this way. I think we talk so much about reducing fragmentation, but fragmentation for what? And that we start early for the patients and people, because basically rehab is so important. I remember when I was in one of our centers in Dnipro, and there was a simple hand injury. But what is simple? But when the person can write after the rehabilitation service, that difference, if you think as a person, what is the difference it makes that you can write with your own hand and use a pen? That's a huge difference. So I think we need to understand the complexity, but what it means for everyday person when we design those services. So just few reflections, but very important that we all try to solve the same issue.
Thank you. We have 3 minutes left. Looking at Erica, I don't think we can do another round of questions, but maybe you can tell us what the questions were about that were coming in, and then I move over to Erin. Maybe she can reflect a little bit on it.
Well, the questions, the panelists have been leaping into the chat to answer the questions, so thank you to them for doing that. But yes, there's quite a lot. It's quite a strong, lead into universal health coverage, and how we can include rehabilitation services in the package of benefits, which we will come to on the 25th of November. So I'll hand back to you.
That's the perfect cue for everybody to join in 3 weeks, exactly 3 weeks from now. Okay, Erin, the keynote speaker always has the duty also to wrap us up here. And so what are your final thoughts here, Erin?
Yeah, I would just wrap up to say that we are very grateful for the privilege to work with the 14 countries and kind of see the strategies that countries are using in different levels of development with their rehabilitation in their own health systems, and kind of understanding where the health system is as a basis. Does it offer universal coverage? And then how does that affect the access for rehabilitation services? Or is it something where rehabilitation is provided by other parts outside of the health system? So it's always important when doing this cross-country comparative research to see what type of health system is at the baseline, to see kind of what may work for your system, and yeah, just see how it matches with kind of the workforce and all of the other resources that are within each system. So yeah, it was great to hear all of the spotlights to see more details behind the work.
Thank you very much, Erin. Also, a big thanks to the panelists from my side and for sharing all their insights. And also thank you to the audience for joining us today. Please join us again in 3 weeks from now, same time, when we are going to talk about financing. Hope to see you there, and stay safe in the meantime. See you then. Bye.